This is where I come. I come from Chile. We are in winter there now, so this is Santiago. Oh, this is the punto. This is Santiago, the city where I live, and these are the hospitals where I work with children. Even though we are in the newborn screening area, we do not have access worldwide. And I think that here in Africa, you don't have access in all countries to newborn screening. And in Chile, it's working in progress. We will have it just in next year. It does not diagnose all, anyway, it does not diagnose all inborn errors. As these disorders are genetically driven, a childhood onset disease and diagnosis before adulthood is expected. However, some patients are diagnosed late in childhood, either because of lack of awareness or due to delay onset presentation. Which ones are seen later in childhood or adolescence in the last setting? And for me, it was when they told me to talk about this, for me it was like, well, it's easy, but it's not so easy. And just to remember that all the diseases in children are due to mutation, or almost all are due to mutations, germline mutations mostly, and some because of de novo mutations. And we have the hypomorphic mutations, missense, splice, donor, and acceptor site mutations that in general cause diseases that are milder and later diseases. So I picked some diseases that you can see more frequently later in childhood. And if you think, and if I ask you, which diseases can you see later in childhood, it's very easy. Which ones? CVID. Okay, so, but I picked some other diseases that you could see later in childhood or adolescence. These are the groups of the US, and in this group, you will almost never seen patients later with later onset. And this was presented already in the symposium, but this is an acid paper with the initial presenting manifestation in 1,600 patients with inborn errors of immunity, including infection and non-infection manifestation. And I don't know if you see it, but 69% of the patients had first manifestation were infections without dysregulation, 9% were dysregulation without infection, and 9% were infection with dysregulation. Of those that had a dysregulation without infection, they were between 6 years. The first symptoms were between 6 years and 25 years. 75% of these patients were under 6 years of all these patients. Also, most of the diagnoses were very early in childhood. And you have also this group of patients, the doctor, I don't remember, but and then they're going to talk about this group. The group of patients that were older had mostly infectious, like the first symptoms. So we have a few patients that you can see later in childhood or adolescence, not adulthood, nor early childhood. And those are mostly CVIDs, but also predominantly antibody deficiencies other than CIVs. Some are in this group. This is the group of the SCIDs, and you should never see SCIDs after a very early childhood. But there is some diseases like ADA, BRCA1 and BRCA2, and Artemis deficiency that could be seen later in childhood. And one is ADA deficiency. This is the most common form of SCID. Typically, it's present at birth or during the first month of age, but there are phenotypes describe it milder later in childhood or even in adulthood. And this is a paper and a report of two patients. There were two siblings, and the older sister was 17 years old with an ITP that was very difficult to treat. And she has a younger sister that had some pneumonia, some warts, some candidiasis, but not very, they were like mild diseases. At the 20s, they had predominantly chest infections. When they were 30s, they were studied and they have CD4 lymphopenia. They have impaired lymph proliferation, impaired specific antibodies, and both patients were heterozygous at ADA locus, and those they were the father had the allele. So this is one report, but there are other reports where you can see some patients later in childhood with ADA deficiency. Then, if you look in this other group of diseases, you can have some patients later with MHC2 deficiency, MHC1, and this one. And in the MHC1 deficiency, you can have mutations in TAB1. Mutations in TAB1, in this group, patients are usually well until late childhood. And they have recurrent bacterial infections, but very mild later, not very important infections, but they subsequently experience recurrent infections of the lower respiratory tract with bronchiectasis and respiratory insufficiency if we don't treat them. They have necrotizing granulomas in skin, mostly in limbs, and they can have also granulomas in the upper airway. Several atypical patients have pneumocystis jirovecii pneumonia, and they can have chronic diarrhea resulting in death during infancy. They are typically those patients who have a very low CD8 patients with CD4 patients that are normal. So this is another group that can be presented later in childhood. In this group, I'm not going to tell anything about them, but there are also reports of later patients presented with CD40 ligand deficiency, ICOS deficiency, or ICOS ligand deficiency. There are reports also of agammaglobulinemia with X-linked agammaglobulinemia in some adults. It's rare, but it could be. And we have all these patients that have CVID. And CVID, of course, we already said that is the most common disease that is present later in childhood and adolescence. These that are marked here are the most frequent in later childhood and adolescence. And of course, if you see how you diagnose the CVIDs, there are some consensus, and two of them say that they must have more than 4 years old. The last consensus say no age requirement, but of course that says that it's later in childhood. Most of them has monogenic diseases, more than the adults, and they tend to be more monogenic than the adults. And one of the diseases that is very interesting is the Icarus loss of function with outflow insufficiency that is here, and it looks like a CVID, like an autosomal dominant CVID, but it's due to an haplo insufficiency in Icarus gene. And you can see here that the age of presentation can go from some months to 60 years. So you can see patients with 8 years or 7 years. This a group of families that were studied and published recently. That's another CVID that you can see in that age. And I'm going to talk, and I picked this one because we had a patient, this is a report of patients with this mutation in this gene, and we have a patient, I don't know if you can see it, but she was a patient that was absolutely healthy during the first 3 years of age. And then when she was 3 years of age, she had alopecia and trichognikia, and she had an adrenal insufficiency. She was treated by the endocrinologist, by the dermatologist, but nobody thought about what's happening with her. And when she was 7 or 8 years old, she started to have pneumonias, bacterial pneumonias, and when she was, and then she was sent to the immunologist. We studied her, and she had this mutation. But when we had the diagnosis, she already had CMV that was everywhere, and we thought to transplant her, but she died before that. So that's patients can present like that in a later childhood. Then you have patients that can have ALPS, not in so early. In generally, we think if you are an HLH. You can think, okay, HLH, it's generally very early in the childhood, but there are some mutations that can present later. We have also the X-Men that can present later. The SAP deficiency and SIAP can present later in childhood. And we have also this other group, ALPS, APZ, CDL4 deficiency are also seen sometimes or many times during the later childhood. And I'm going to present this one because this is a family we have. This is, I don't know if you can see, but they are two sisters. The eldest one was seen by us when she was 8 years old because she has granulomas on her legs, and we studied her a lot. We couldn't figure out what she had. She had biopsy, and even we made an eczema. And at the eczema, they didn't tell us exactly what she had. It was like 10 years ago. And then she had a little sister. And this sister presented with an HLH when she was 5 months old. So we had a panel, it was easier. We sent a panel of her, and she had a mutation in FES. When we went to the eczema has the same, was absolutely the same in her sister. And both had ALPS, and the father was studied too, and the father only has splenomegaly with the same mutation. So there is an incomplete penetrance in this in ALPS, and less than 60% as this incomplete penetrance, and the penetrance correlates with the location of the mutation in the protein structure, lower in the extracellular compared to the intracellular domain, because mutations in the extracellular domain led to haploinsufficiency. So maybe that's what happened with this family. And if you see this survey of 90% with ALPS, 7% were affected in an adult onset disease, average 18 and 30 years. The range was 18 and 35 years, and there were patients that were under 18 years old. And the median age of presentation was 3 years, but you had patients with 10 or 9 years that presented with ALPS. And then we have these two, LED1 and GETA2. LED1 in January, and all of you knows that it presents very early in childhood in general. They have less than 2% of CD18 expression, but there are some patients with moderate phenotypes, with periodontitis, with these ulcerations of the perianal area, and this impetigo in the cheek. These patients are not very often seen, but we always have to be like certain if one of our patients with periodontitis may have this disease, and this is due to the dysregulation of interleukin-17 and 23, and they can be treated very well with some biologics. And GETA2 is a disease that has a highly variable penetrance, and so the manifestations goes from infancy to adult age. And a possible hypothesis for this variable penetrance is that the trigger of this syndrome might be evoked by somatic mutation in these genes, as they commonly occur together. So I'm always like looking when there's a patient with lymphedema. I always look if they have monocytes or they don't have monocytes, and see if they have something in their blood count, under their, if they have something that can make you think about myelodysplasia. That's something that we have as pediatrician. Even though you see more GETA2 in adults, you have to be aware. And this is the natural history of 79 French and Belgium GETA2 deficiency patient. As you see here, the age of onset was later, but you can see in the childhood and adolescence age some patients of these. You can have also some patients with Mendelian susceptibility to mycobacterial diseases with this, mostly with these mutations. I'm not going to talk about this because it's too long. And we also have these patients. And those patients with other hidradenitis suppurativa are not going to die because of this, but they have these kind of lesions. They occur after puberty. This is absolutely started during adolescence, and they have symptoms during the second and third decades. Mostly they are females. They have this chronic inflammation in the skin. It's very painful. They have miserable life sometimes, and it affects around 1% of the population. They can be very mild or severe. And I have like 15 patients right now with severe, this kind of severe hidradenitis. And when they are severe, they go and you can treat them very well with some biologics. So we have to think and study them. They are related with this gene. I usually do the panel. I usually go and for the genetic testing, but you do not need a genetic testing to treat them. And lastly, we have the autoinflammatory diseases. There are some autoinflammatory diseases that are only seen during the neonatal period, that is NOMID. But the other ones, you can see almost all the autoinflammatory diseases during the early or adolescence age, and mostly the FMF, TRAPS, A20 upon sufficiency, Muckle-Well, CAPS, ADA2, and STING, Blau syndrome, KEMS, and DITRA. But we have other patients that looks like autoinflammatory diseases that we are doing research and doing the test to see which is the gene that really is provoking the autoinflammatory disease, because they're still growing and growing. So that's what I wanted to say. I hope I was on time. I didn't talk about other diseases because it's too long. This is the LASIK group, and I'm representing them.